I think you have a nice view of recession on the central incisors, and you'll note that the tissue is very thin there as well, with no attached gingiva. Then tooth number 26 is missing. That's a cantilever prosthesis with a crown on the canine. Very slight recession, but very thin tissue on the canine. And then recession on the premolar, number 28, a little bit on 29 as well. 30 seems okay. So I might include 29 in the procedure. You know, we have the choice of the two methods, the all-tunnel or the alternating tunnel. And if we look at this with a probe and look at the interdental region, there's nice space here in the sense that there is integrity of the papilla from facial to lingual. Same thing here. This is a way of checking it, is just pass the probe through, and it gives you an idea of the width of the papilla at the crest. It's a little close here next to the ponic, but of course there's no root in the tissue there. This is just going to be a bit of a challenge, and it just means that if I am unable to go under this, I don't certainly need to elevate this, I just need to get underneath the tissue in this region. If it proves difficult, then we just make an entry incision to gain access. As we come around the canine, again, very thin margin. I think you can appreciate that. Turn to your left just a little. I think you can appreciate the thinness of the tissue here as well as on premolar. And then as we come to the second premolar, it's okay, but it probably would be enhanced to augment that a bit as well. It's absolute requirement on the first premolar canine and both centrals. Then it's just a matter of extending another tooth to be a little bit better. So we'll do light root prep. It doesn't appear that there's any significant problem. I think you'll notice too, or you should be able to tell, that this is a little root form in the crown that's on the canine, and there's only the slightest amount of recession present on the canine. So we augment here. Yeah, this won't be root coverage on the canine, but we'll elevate to cover some of the premolar behind it. So I've already anesthetized with just local infiltration. And if you'll turn toward me just a tiny bit, the first step is going to be just light root planing. So I'm just cleaning the root surfaces missing. And you can see I'm using a younger good 7/8. And you can get an idea of the condition of the surface of the root. It's really pretty hard. I'm just doing light freshening. And I think you can appreciate that there's excellent hygiene here as well. Fairly typical of most recession cases, that there is very good hygiene. In fact, it may be part of the cause of the problem is a little aggressiveness with hygiene. That, of course, on top of a thin tissue. So our goal here is to gain back a more resistant tissue. And I'm just root planing part of the roots that I can reach from my position. And turn to your left, not just a little, behind the patient. And I will change to the front position in just a second. So a little bit of a notch here. And we might, on these notches, use a little sonic. There's a notch here, too. I think you can see that. So I think I will actually sonic these two. At this moment, we're principally interested in the premolar region to gain access for sonic. So I'm doing an intrasulcular incision with the Orban. Trying to stay just absolutely within the sulcus intradentally. And extending that to the lingual aspect. And I'm going to extend this around the canine. See if I can slip in this way. And now this is the elevator that we talked about, the micro elevator. That's the curved end, and we can use it curve both directions, either direction. And I can go beneath the papilla and just rotate it slightly. To start to gain a little movement. Is that showing okay?
Yep.
And just work my way around that tooth, rotate some under this papilla. And the idea here is this does not overly stretch the sulcus. I'm actually going to use curve down here for just a second. And I'll curve back out. And the area between the teeth is, if you can get that free, is a big help. There's always, of course, an indentation in this region, and I'm trying to curve into that. At some point, I may have to block the view in order to get the angle that I can reach it. It's a little bit of a trick to show everything. I'm certainly trying to. And all of this tissue is thin. Of course, there's a very thin marginal tissue and then thinner mucosa. And that's, of course, why we're doing the procedure, is to enhance the resistance of this tissue. But the idea is, if you can get past that rolled crestal area, it starts to move more easily, getting nice movement here. So I'm going to switch to straight and see if I can do it without blocking. I'm just working my way under that papilla, moving distally and slightly apically. Now rolling around the tooth, good separation facially. Straight end again. And just a little bumpy, indicating a little irregular crest there, showing now. And just want to be a little cautious. Again, the critical areas are mucogenital junction, and the mesial of the canine. I'm under this papilla really well, so you can see the instrument through there, I believe. I'm using the straight end again now. But there's a serious undercut right there. That's what I'm trying to negotiate. And with the curve pointed downward, it's a little easier because I've relaxed the margin. That gives me the ability to do that. So now I'm going to come back with straight and work my way around the facial. I've got good movement there. So I'm going under that papilla, you can see, fairly horizontally. And it's because I've gotten some stretch of the margin, or I couldn't do that. So I'm going to come back from above, use the curved end on this second premolar. So I'm just using a little pressure and little just rotation of the instrument. And we've got pretty good mobility at this stage. So I think we can just loosen this way just a little bit. And this is on the mesial, the molar, so I'm just trying to get under that papilla to mobilize that region. And now I think we can get access to do the sonic root prep. It's not a great deal here. Okay, we get a view of this instrument. This is the Diamond retrofill instrument on the sonic handpiece, and it's a Cavo Sonic Soniflex 2003L. So we're going to get the line angles where there's usually a sharp edge and flatten off that projection. Get this other line angle area in the margin. And then do the same thing. You see a little notch here. So we can just work that down. And after that's finished, I always recheck those root surfaces with the curette. Turn to your left for me. Is that better? I think the root prep is one of the underappreciated steps, and a very important step. And now we'll use the EDTA on all of these roots. I'm just using a cotton tip applicator and just rubbing this across these areas that we've root planed. And this will remove the smear layer as well as function as an antimicrobial agent. Now then, we've done the initial blunt preparation on the premolars and the canine. We have not done the incisors, so I've done 3 teeth and have 3 to go. And so we'll do the intrasulcular incision first, and we're going to include 23, 24, and 25 now. So I actually will make an incision in the sulcus of 22 because we extend to 22. We'll be treating the other side another time. And now we'll do the same process as before. You notice we've looked at papillae before and feel that they can tolerate the lifting. So I'm using the curved end downward again. I'm just trying to lift that from the crests. Just a little pressure, Missy. It shouldn't be bad for you. Staying awake?
Mm-hmm.
Turn toward me just a little. Perfect. This one's a little easier because I've been under more than half of that papilla, completely under it now. It's fairly narrow. Should be the same thing true here. Am I blocking you there a little bit? And I'm just engaging the crest and then rolling because that's with the curved surface outward. You see, in other words, if I went in this way, the curved surface down, I can't get under that. But this way, I can get under that papilla. And I'm just rolling a little proximally and a little apically. Get that initial foothold. I'm going to go straight now, straight end. Now I'm doing a lot of good there. Just had a little trouble getting that started. It's okay. And it looks like right there might be just a tiny little pinch. So I'm concerned about that. I need to be cautious. Yeah, but it's a little early warning. So I'm going to come in from this way and work toward that. See if I can lift that papilla. So I'm going to come in with this instrument straight. I'm going to try to enter here and get to there. And get under that some. So I'm somewhat close to it. Coming from above now. Good. Because I did a lot of good with that move. That's the curved in, curved upward. And I'm well past that delicate area. And in fact, real close to about that point on that side. Working toward the midpoint from the other side. Or we're going to continue the pouch preparation. So I'm just going under this papilla with a younger good. To free it. Turn toward me just a little. Good. And just rotating it, trying to engage the crest with the edge of the curette and just lift it. And turn to your left. Does that show? So I'm going right over the top of the alveolar crest toward the lingual to create space beneath that papilla. Now then, we'll do the rest of the pouch prep and using the modified Orban for that purpose. So I'll start into this area that I have already lifted it to some degree. There's just a little lateral movement cautiously to start. I'm just moving this a little apically and a little laterally as I work my way around and start to free that area. So that was one central. Can you still see? I think you can appreciate the thinness of this tissue. And I'm going to do the lateral now. Trying to gain a little relaxation as turn toward me just a bit. Good. Thank you. And I'm having a little struggle there, so I'm going to come through the other side and free toward that. And I'm stretching the lip, I don't know if you can tell, to stretch out the mucosa, but the problem right here is a roll, osseous roll with an undercut. So the need to be a little cautious to get further apically, which I've done now. Now moving distally. Still having just a little difficulty, so I'm going to enter through the central again. Try to work my way past that roll. And the edge, you can have a little, you need to be careful of the edge of the instrument. And actually, let me use the elevator and see if I can free that a bit more. Because we want to, if we don't free this, there can be a problem here. Maybe just a little too bound down in this region to allow me to get under it. So I'm going to do this with the elevator, and I'm hitting quite a roll here. That's what can lead to difficulties. Over that now, getting past it, but there was just a much larger roll there than any place else. So I'm just doing more blunt to get well past that area with this directed, the curve directed downward. Now I'm going to use the straight end and see if I can get past that. I think I'm past it now, so now we go back with the modified Orban. And now then we'll move to the central and work toward the ponic area. And moving laterally again and apically. So again, working apically and laterally. What you want to do is just make sure that there's no tags that block the continuous pouch. Make sure that it's clear. So just retrace this preparation, which is all supraperiosteal. It's a real irregular surface beneath there. And now we've moved it. And we'll measure this. With the probe again, you can do this a lot of different ways. I'd like to use the probe. It's 22, 33, 34. And I've added just a little bit to this length to help me in the edentulous area. And then we want this to be between 6 and 8 is the typical measurement I use. So I'm going to use 7. And we'll place the graft from the incisor toward the posterior. It doesn't really matter so much, but that's I think going to be a little easier entry using the Younger Good 7/8 curette. And see if I can start with this incisor, which is the second tooth from the end. Let's slide out now and hold the edge. Okay. A lot of times it wants to go a little bit vertically. And then once you get it going, just a little patience. Okay. And our trick is going to be getting past the pontic. So just working a little bit more and give it a little more freedom of movement. Sometimes what I'm doing is using my thumb to nudge it at the base. In other words, the base of the vestibule, working it up. There it is at the canine, which means it's past the dentulous area. There it is. And Shannon catches that edge, because what we want to do is bring it out at this end. And see the end, and that's the end now. What I want to do now, I need to get this over to the lateral incisor. I'm worn out, is that what you said?
Mm-hmm.
Yeah, I am. This is tedious, is all.
Mm-hmm.
In case you're wondering what I was going to do, I've decided I'm going to tie it off twice. This is 6-0 polypropylene suture. I couldn't get the designer one that I wanted, but this will have to do. It's a pretty blue. You like blue?
Matches your eyes.
So we catch this about 2 to 3 millimeters from the end, and we want the suture to loop over the top instead of the side. And then we'll work this under that papilla. And then when we pull the end, and I'll go back through the embrasure now, that will draw the end of the graft under the papilla distal to the lateral, or between the lateral and the canine. And Shannon is using the micro pickups to help me as we go along, and now we'll use a little pull on that, draw that graft under that papilla. And we'll check that positioning as we go. Keeping the end of the suture in view. And the end, I mean, Shannon will show you with the pickups, is that end. So I'll come through the embrasure now between the lateral and the central, and I need to cross under the papilla, because all of this will be subgingival placement. And it's easier to do from the facial, so just cross under this. Don't tease me. And again, checking that in, pulling it in place. And we'll catch the graft at the distal of the central, the left central, so we'll catch it right here. Just the graft, not the papilla. And then go through the embrasure. And then Shannon will capture it lingually. Pass it to me. And you can see that start to pull the graft coronally and also lift the papillae slightly. And now crossing from lingual back to facial, between the central and the pontic. Already to the pontic, isn't that nice? Pontic meaning false tooth. But then being a periodontalist, you knew that. And we'll catch this distal. Ensuring that it's a sufficient bite. Then I'm going to cross back to the lingual. Shannon picks it up. And now I'm going to go back to the front. I'm going to tie off these in sections because of the pontic. So I'm going to go back now between the centrals and cross under the papilla. And Shannon is helping me get under that papilla without touching or penetrating anything. Now we'll catch the distal. Hold on, let me get that out. Good. Thank you. Go through the embrasure. Under. Thank you. And back between the teeth, and then we'll tie this and then we'll trim that. Start, or between the molar and the premolar. So we're doing an end and working to the ponic as we did before. And again, approximately 2 to 3 millimeters from the end of the graft. I'm just going to slide the graft now under the papilla, trying to hold the suture in place. So now we'll come around, and I think this may be open too, we'll find out. And there it is. It helps a lot to lift that area from the opposite side as Shannon did. Then catch the graft on the distal this time. We're doing distals forward toward the anterior, then we'll do mesials as we go back posteriorly. Through the embrasure. You can see that lifting the papilla. Around the tooth. We go under. And it passes pretty easily. And we'll come through the embrasure, the ponic, distal, I'm sorry, check getting the mesial, the canine, not the distal, the ponic. And bring that one through. And now go back through that embrasure. And we'll go under the papilla. She's lost faith in me, Missy. You haven't though, have you?
Mm-hmm.
Great. It's good to have somebody on my side. You can see that lift that papilla. I went through the embrasure like that because it's open. or through the contact, I should say, because the contact is open. And that's good. And Shannon is holding the suture in for me because we don't want that to come back through. As you know, that had an open contact, so it's positioning of the graft as well as the open contact situation there. We draw that in and we do the second tie. Good. But you can see the appearance after suturing the graft. So you don't see any sutures. There's 2 ties on the lingual, and the graft is positioned over 2 premolars, canine, and 3 incisors spanning a ponic area. And actually, let's start with this incisor, and we'll do the margin next to the dentulus area. I need a pretty good bite here because this is so thin. Using the instrument as a separator. And this will be a series of interrupted sling sutures. So I penetrated the margin about the root line angle, about 3 millimeters from the crest of the gingiva. And Shannon indicates where I should place the suture next. It's a real big help because there's a whole lot to watch and pay attention to, and your assistant is just a very key part of this procedure. I'm using 6-0. We've done this with both 6 and 7-0. They both are satisfactory for the purpose. There may be some slight advantage of one versus the other, but overall, is that easier if I turn it up? You're welcome. So you see we're able to draw that up totally over the graft. That's the idea. What we're trying to accomplish here is to create a zone of dense collagenous connective tissue that's bound down beneath the overlying mucosa, providing stability for the area. So again, root line angle. Sometimes when you have significant recession and you do this, the papillae will bunch up, and it looks like there's a problem from that. There's not. It dissipates. You'll see that in some of the slides tomorrow. In this case, I don't think you'll see that because the recession's not so deep relative to the new position we're achieving. Thank you. This will complete the incisors. There's a little bit of graft exposed on one incisor. Otherwise, it's not exposed any place. And we can test that and see if we can sneak it back under. But if it's up there, it'll probably want to come back. Might have done that where I compressed it, but usually if it comes up, it'll continue to come up.